Hello everyone, Floyd here with Curbside to Bedside. We're going to talk about needle thoracostomy and why it usually goes wrong. So what happens when a patient develops a tension pneumothorax? Well, the classic teaching is, and this is correct, at least the initial part is that the patient has some trauma, they have a rib fracture, they have a knife wound to their chest or a bullet wound, and it creates basically a hole in the chest or a hole within the lungs, and it allows air to escape from the lungs and enter the pleural space. So once you break the continuity between the pleural lining, air enters, and as the patient inhales, they keep taking a breath, air continues to enter this pleural space. And the way that we envision it is that the lung collapses, and as the patient keeps inhaling or as we continue to ventilate the patient, the lung gets smaller and smaller and smaller. So we decompress, generally at the second intercostal space midclavicular line. We get this big escape of air, the SpO2 improves, blood pressure comes up, and all is well. So this is kind of an overlay of how I initially envisioned a tension pneumothorax happen. So the patient has their collapsed lung. You can see my small lung there on the right. The patient gets a collapsed lung, and it starts to put pressure on the great vessels, and they start to kink off. There's a problem with this kinking theory, though, because we were taught that spontaneously breathing patients kink, ventilated patients kink. Basically, all patients with a tension pneumothorax kink these great vessels. And the presentation of a patient with a tension pneumothorax includes someone who is hypotensive with tracheal deviation and JVD because of this kinking effect. However, that is wrong. It is wrong because of dogs. Yes, I said dogs. Most of the studies that looked at the effect of kinking via a tension pneumothorax were extrapolated from animal studies, and most of those subjects were canines. Now, there's a problem with canines. Canines have a pliable mediastinum or a flimsy mediastinum, and this is an article that dates all the way back to 1939, and the author says that dogs have not been suitable as experimental animals because of the flimsy and often perforated mediastinum. In both the rabbit and the goat, the mediastinum is intact, but the goat is the more satisfactory because of its size, larger blood volume, and the apparent similarity of its mediastinum to that of man. So the question that we're going to answer is, do patients with a tension pneumothorax, with a unilateral tension pneumothorax, have a decrease in cardiac output? And when do they have a decrease in cardiac output? And is that due to the kinking effect? The answer is it depends. So we have to reframe how we look at tension pneumothorax as a disease instead of one disease with a single clinical presentation. We have to look at it as two different diseases. We have to look at it as we have to differentiate between a patient that is spontaneously breathing without assisted ventilation, and we have to look at it in a patient who is not spontaneously breathing with assisted ventilations. And this is not something that I personally have came up with. Recently, Simon Lee Smith was interviewed by Scott Weingart on the MCRIT podcast, and this reinvigorated me to do a deep dive into it and develop a podcast. I originally heard Simon Lee Smith interviewed by the Femcast podcast a few years ago, and when I originally listened to that podcast, I was just amazed by what he was saying. It challenged my entire belief system surrounding how patients present with a tension pneumothorax. So Simon Lee Smith basically describes it as basically differentiates the clinical presentation between patients that are breathing unassisted and patients that are breathing assisted, so i.e. with positive pressure ventilation. In the unassisted patient, the main difference is that they will have a low SpO2, but their cardiac output and their blood pressure will be maintained. So they will present with hypoxia without hypotension, at least originally, and this is because the patient is able to compensate on the contralateral side of the pneumothorax. So if we're talking about a unilateral pneumothorax, which most pneumothoraxes are unilateral, they have these very wide respiratory excursions. So they have this negative intrapleural pressure that helps to stave off hypotension, at least for the first few minutes, sometimes hours. Then we have to think of the patient who is breathing on assisted ventilation. That patient, unless they are breathing spontaneously on the ventilator, that patient does not have the ability to compensate on the contralateral side by increasing their respiratory rate and taking very deep inspiratory excursions to stave off hypotension and help augment blood flow and cardiac output. And they have positive intrapleural pressures throughout the entire respiratory cycle. You can infer that that patient would present more precipitously as classically taught. So here are just a few of the signs that were mentioned in Simon Lee's papers, and these signs also challenge our traditional view of how patients present with attention pneumothorax. You will see in ventilated patients, the universal findings are rapid onset, an immediate and progressive decrease in SpO2, and immediate reduction in cardiac output. And in these patients that are being ventilated, we can typically infer that if their blood pressure is low and they are hypoxic, that their blood pressure and hypoxia is likely low because of a pneumothorax if we have other common findings. Simon Lee Smith also mentions on the podcast that hyperexpansion and hypermobility of the ipsilateral chest, so on the same side of the chest, might be present more often, but it is a pretty elusive sign because it's difficult to pick up on that if you're sitting on the patient's side. You have to be at the patient's head or at the patient's feet usually to appreciate these findings, and they could be extremely subtle, so it could be very difficult to pick up on these. Now, in patients that are awake and spontaneously breathing, the universal findings change. These patients generally present with chest pain and respiratory distress, and another common finding is tachycardia. But you'll note that hypotension is not a universal or even a common finding in the awake patient with attention pneumothorax for reasons that we have previously mentioned. So just to summarize really quickly, patients that are breathing spontaneously generally present with progressive hypoxia, and their cardiac output is maintained by an increase in their minute ventilation. So if you are performing a roadside assessment for a patient with chest trauma and they are hypotensive and breathing spontaneously, then you should investigate for another cause of the hypotension. And as to paraphrase Simon Lee, if you have a hypotensive, spontaneously breathing trauma patient, you should first search for bleeding, and bleeding, because the number one cause of hypotension in a spontaneously breathing trauma patient is bleeding. If the patient's breaths are being assisted by positive pressure ventilation, then they deteriorate rapidly and they might present with a sudden fall in SpO2 and can become hypotensive within minutes. Since we were pretty much universally taught that these two disease processes, these two patients present similarly, we have to reframe our definition of what attention pneumothorax is. And I searched high and low for a definition, and I actually found it in a reply to one of Simon Lee Smith's papers. And the author of this response redefined a tension pneumothorax as a pneumothorax that results in significant respiratory or hemodynamic compromise, the later especially in ventilated patients, that reverses on thoracic decompression alone. I think this definition to me makes sense, that tension pneumothoraxes are, in my opinion, and in my anecdotal experience, it can be very difficult to actually appreciate the clinical findings of a tension pneumothorax. And the classic findings of JVD, tracheal deviation, are so uncommon and unreliable that we should almost just wipe those from clinical signs or symptoms of patients with a tension pneumo. And I think that it is true that sometimes you won't know if the patient has a tension pneumo or not until you decompress their chest. And if you have a successful decompression and the hemodynamics and SpO2 and vital signs improve, then that is the best way to confirm that the patient did in fact have a tension pneumothorax. So how do we treat it? And I think to know how to treat it, we have to talk about why needle decompression fails, and it does fail frequently. But it fails for a multitude of reasons. And I would say the most common reason is that we are A, going in the wrong anatomical location, and B, using inadequate needle length. So if you look at the picture on the right, if you look at the needles that are in the second intercostal space, or at least I think they might be in the second intercostal space, and if you look at the ones that are on the anterior portion of the chest, if you say that those needles are correctly placed, then you would be wrong, and you should keep listening, because at least two of them are placed way too medial and not on the midclavicular line at all. So basically, for decompressing a patient, we have two options. We can use a very long and a very large bore needle, or we can use our standard 2-inch IV catheter and hope that we reach the pleural space with that. So if you are still using a 2-inch needle and only allowed to stick it in the second intercostal space on the midclavicular line, the vast majority of the time you are not going to be in the chest. So the average chest wall thickness at the second intercostal space is about 1.8 inches, give or take about half of an inch. And this is just the average chest wall thickness. Now there are deviations to this, and some patients may have much thicker chest. And that's not even taken into consideration patients that could also have subcutaneous emphysema, which could increase the chest wall thickness. However, at the fifth intercostal space, you'll see that the average chest wall thickness is 1.4 inches, give or take 0.04 inches. So it is very possible that you could successfully decompress a pneumothorax using a 2-inch needle at the fifth intercostal space anterior axillary line. Now, the success rates for decompressing a chest at the second intercostal space are pretty abysmal, and I find this surprising since the majority of the major trauma recommendations have now recommended a needle at least 3 inches and are now advocating that we switch from the second intercostal space to the fifth intercostal space. At the fifth intercostal space, the success rates were 100%, and that was even using a 2-inch long needle. But at the second intercostal space, it was less than 60%. And this is actually in line with what I've heard from our trauma surgeons at our local trauma center. They have told me that about 50% of the needles that are in the chest actually do not decompress a pneumothorax. And if this is not compelling enough, I think there's another reason that we should probably move from decompressing at the second intercostal space, and that's because we're just not good at it. Now, this is a study conducted that evaluated the ability of 25 emergency physicians to correctly name and identify the second intercostal space. But I would argue that if you polled your paramedic or nursing colleagues, you would find similar findings. We don't appreciate that the clavicle actually extends all the way to the shoulder, and we think that it stops short of the armpit, so it kind of makes sense for most needle decompression sites to be too medial. But there's problems with sticking the needle too medial as well. Now you might be saying, well, I like the second intercostal space. It's easier for me to find, and I'm more comfortable with sticking the needle in the second intercostal space. And I use a long needle, so I'm pretty confident that I can reach the pleural space with that needle. And if that is your argument, I will contend that most of the studies that I am referencing do look at a 14 gauge 5 centimeter, which is about 2 inches long, at the second intercostal space. But there's another issue with inserting a needle at the second intercostal space, and there's a lot. And the problem is that there's a lot of bad stuff at the second intercostal space. There's the subclavian vessels, there's the cardiac box. We really do risk causing more harm, and there's a multitude of case reports on this showing that a misdirected needle at the second intercostal space can create a lot of badness. Now, if you're saying I'm very skilled at finding the second intercostal space, I go perfectly perpendicular to the skin at a 90-degree angle, and I'm very confident, and I've followed up on every single patient that I've stuck a needle in the chest on at the second intercostal space, and it has not caused any damage, then that is hard to argue with. However, I personally prefer the anterior axillary line depicted in this image as C. For me, personally, I think it is easier to find. I've had a hard time actually palpating the intercostal spaces on certain patients with very thick chest walls. Additionally, it's hard for me knowing exactly what midclavicular is. You could say, well, I'm just going to go about the nipple line. I think that's probably accurate. The nipple line, maybe the nipple line and a little bit further over. But personally, I think if we train on finding the right location for the anterior axillary line, that we're going to find not only higher success rates in decompressing the chest, but we're actually going to cause less harm by doing this, and providers will probably feel more comfortable with that once they've had some practice. Now, this is our model, and using this model, I'm going to put a triangle right under his armpit. This is referred to as the safety triangle. Theoretically, and this was derived from chest tubes, but theoretically, if we draw a line at the base of the axilla, and we draw a line at the lateral edge of the latissimus dorsi, and then we draw another line at the lateral edge of the pectoralis major, then that makes up our safety box. And we can successfully and safely, theoretically, insert a needle into the chest here. So if we're off just a little bit, if we go a little too anterior, a little too posterior, it's not going to be that big of a deal. But our goal, again, is at the fifth intercostal space, which in males can be found about at the nipple line if we follow that around. Or in females, I like to find the xiphoid and then go around from there, which should correspond pretty well to the inframammary fold. Now, my safety triangle may be a little off because in this model, the latissimus dorsi and the pectoralis major are not well defined, so maybe we should choose a better model. You may be saying, well, somebody has punctured the heart. You showed us an image of a needle actually going in the heart. What is the chance that by decompressing a patient at the anterior axillary line, fifth intercostal space, that you would puncture the heart? Well, I'm glad you asked because there is some good data on this. This was a radiographic study trying to determine the incidence of one successful decompression And two, they actually measured the depth of vital structures to determine whether or not there would be an injury or non-injury. And they measured the depth of vital structures defined as a distance from the skin surface to the intersection with vital structures. Now, I want to make a special note that they looked at the closest vital structures perpendicular to the chest wall. And they said that if the if the depth to vital structures was greater than 80 millimeters, then that constituted a radiographic non-injury. So what were the results? Well, they unfortunately had a radiographic non-injury rate of 68%. This was isolated to the left fourth intercostal space anterior axillary line, which is not that good. So that non-injury rate is pretty low. However, the caveat is this is assuming that the needle was not perpendicular, not perfectly 90 degrees. Now, if we're sticking a needle in the chest and we're pointing it directly towards the heart, then clearly we could cause some injury there. The authors did specifically note that with the steeper angle of entry, the average depth of vital structures at the left fourth intercostal space anterior axillary line, the radiographic non-injury rate improved to 90%, which is not statistically different than the radiographic non-injury rate at other sites. Now, I think there are devices coming on the market. There are new and improved devices. Now, this one is the Spear, which is made by North American Rescue. I particularly like this device for a multitude of reasons. The first being that it has a whistle that sounds when you enter the pleural space. I don't know how good this whistle is, and I don't know how much air it takes to actually make the whistle work, but I like the idea. Another thing that I like is that it has depth markings on the catheter itself. And what North American Rescue actually recommends you do is they recommend that you insert the tip of the needle until you hit rib. And then they recommend that you mark 3 centimeters from that and you proceed on 3 centimeters more, at which point you will decrease the angle of the needle and slide the catheter off. This catheter is a larger bore, so it's a 10 gauge needle, and it has fenestrations in the catheter so that if the tip's occluded, then air can still escape, and it's more difficult to kink. So these devices are getting better and better and better. Having an indicator, in my opinion, is probably the most important thing that device manufacturers can do, because it lets us know when we're actually in the pleural space. There is a caveat to that, though. We have to be very careful because a large portion of patients with tension pneumothorax do have subcutaneous emphysema, and we want to make sure that we don't have a false positive when we insert the needle, the indicator change, and think that we're actually in the pleural space. But I think any rational person should be able to appreciate that if you insert the needle a quarter of an inch or half an inch and your indicator has changed, that you're probably not in the pleural space. There are a lot of other devices on the market, and I don't recommend any particular one. There are some that monitor for CO2. So some have a spring and a valve that have a spring that release once you punch through the chest wall and into the pleural space. So it has a color indicator that changes. All of these devices are great, and they only go to enhance and improve patient safety. So this is a 10 gauge needle. Do we really need bigger needles? The answer is probably yes. Our 14, maybe even 12 gauge needles probably don't release air faster than it's coming in. So our needles likely are not evacuating air fast enough for the air that we're delivering. And this is, in my opinion, probably more true for the patient who's being mechanically ventilated. We need a larger hole in the chest. And I think that eventually we're going to use narwhal tusk and stick everyone in the chest with narwhal tusk, because I think the problem with using larger and larger needles is it gets harder to actually get through the chest wall. I don't know if anyone has used a quick trach, but you essentially have to bear down on the patient's trachea in order for it to go through. But when you use a larger needle, you're going to have to push harder to actually get through the skin. And when you're pushing harder, if it suddenly releases, then you risk going all the way through and going too deep. So maybe there has to be a balance. Anyway, that's all I have for now. Hope you enjoyed this. Please let me know if you have any questions. Bye.